fortunate to have three exceptional panelists to actually build on our discussion today, each representing a different sector of the workforce that has had to grapple with some of these really difficult issues related to burnout in healthcare throughout the pandemic. And so first, we're going to hear from Dr. Joshua Gramling, Director of Occupational Health and Wellness and Jail Health Services at Hennepin Healthcare. Then we'll talk to Dr. Myra West, a clinical psychologist and human resources director of Organization for Trauma Resilience at Marshfield Clinic Health System. And then next, Dr. Casey Clements, he was highlighted as the winner of basically where burnout occurs more often in emergency medicine, and he'll present on his work as a consultant physician and assistant professor of emergency medicine at Mayo Clinic in Rochester. And then following these three presentations, you'll have an opportunity to ask questions of our panelists. We'll bring them all together. Again, feel free to enter your questions in the Q&A box, just like we did with the previous presentation. And with that, let's go ahead and start with Dr. Gramling, a graduate of our own Occupational and Environmental Health Nursing PhD program. And so with that, I will turn it over to you, Josh.
Thank you, Dr. Bender. Good afternoon. Thank you, Dr. Bender, and hello to all streaming out there on Zoom. As Dr. Bender noted, I'm the Director of Occupational Health, Wellness, and Jail Health at Hennepin Healthcare. Our main hospital here in downtown Minneapolis is HCMC, which many folks may know the name more frequently. Next slide, please. So specifically, I'll be talking about violence in healthcare and its effects on burnout, and just give you an idea of the baseline here. What we've seen in the past decade is a pretty significant increase in violence in the workplace, and especially in healthcare. So in the graph on the left there, we see a 50% increase over the course of 7 years from 2011 to 2018 amongst healthcare workers being the red bar. And so healthcare workers do experience 73% of workplace violence related injuries in the United States. And yet we're only 14% of all workers in the United States. So we certainly suffer the greatest burden of workplace violence here. Next slide, please. And this probably goes without saying, but it's still worth saying that workplace violence leads to burnout for healthcare providers. So the Minnesota Nurse Study conducted over 20 years ago here at the University of Minnesota demonstrated long-lasting psychological effects for nurses who have experienced workplace violence. And this has been corroborated over and over in the literature throughout the globe of the effects of workplace violence on all healthcare providers. I think there's been a greater focus on nurses in healthcare and their experiences of burnout. But there's higher psychological distress, PTSD, and intention to leave the profession when folks have suffered workplace violence. Next slide, please. And so it's a little too early for BLS data for 2021, but here in our organization, here are the numbers for us. And these are just shouldn't say just, but these are the number of assaults experienced by healthcare workers that we have recorded. There are likely more that were not recorded, but what we are aware of is, 513 assaults to healthcare providers in the last year. So much more than one assault per day amongst our care staff. And what we've seen since 2019, which for us was our largest year of workplace violence previous to this year, is a 25% increase over 2019. We have a huge increase over last year or the previous year, 2020, but level of risk was also less, as there were less patients, inpatient at the hospital, as well as visiting the emergency department. And really, this is in the realm of how we see violence in the environment throughout the country, likely throughout the world. I'm guessing most folks here have experienced some form of road rage from other drivers. We know State Patrol has said that there are more aggressive drivers and more speeders on the road than in almost any other year. And certainly, I am sure that everyone here is very much aware that that it was a banner year for unruly passengers on airlines as well as in airports, but per FAA, far above and beyond any other year for violence in these settings. So really, this comes in the realm of increased violence globally across the board in our country, and a very significant increase within our hospital, and I can only assume other hospitals as well. Next slide, please. And I want to give this example of one area that was particularly challenged last year. So this is our Med-Surg Ortho unit, and Med-Surg Ortho also had the distinction of being our COVID containment unit in 2020. So they had a bit of a double whammy in that in 2020, they were designated as a COVID containment unit because they had all private patient rooms. However, this nursing workforce, at least, was not quite as prepared as others as far as being respirator fit tested and having experience with infectious disease quite the same way perhaps some other med-surg units did. And I think had the general feeling that they didn't have the organization at their back, is what I heard from some, the feeling that the staff were risking their lives, the nursing staff particularly risking their lives, but didn't feel like the organization was doing what they could to make them safe. So whether or not this was reality or not, this was certainly the perception of the staff in the department. And then what we saw in 2021 is that after they no longer had the designation of COVID containment unit because COVID was really everywhere, they became the location with the highest rate of violence, and it became very significant. And the level of burnout among the nursing staff, in particular in that unit, became rather severe. And so we've spent a lot of intensive time working on how to respond, but still have quite a ways to go. Next slide, please. And so even beyond the actual physical workplace violence, so the assaults that take place, there's the overwhelming, to some degree, amount of abuse that is experienced by staff. And, and the staff are very much aware that this is something that's taken outside of our walls and brought into the organization. This picture was just taken yesterday. This was on a unit in our hospital where a family member wasn't very pleased with being told that they couldn't have their family member have an intervention anyway, so I'll kind of leave it general as that. But anyways, reacted with this sign on the patient's board, and then also later threatened the staff that they know that they'll wait outside of work for them after they get out of work. So this is compounded with so the visitors are on edge for reasons. One, there's just kind of the general kind of irritability going on in the community. And then specific to COVID, the patient's visitors the patients can't have visitors to the levels they've had before, increasing the irritability of the patients. And then also patients can't be discharged on time, partly due to supply chain issues and getting patients out the door. So increased irritability there. But it goes beyond that. And so that visitors coming into our environment don't seem to have much capacity for self-restraint. Even just 2 weeks ago, we did have a police officer. We had to call security on a police officer who got up in the face of a nurse because they were asked to wear their mask while they were in the hospital. So it seems to be at all levels of our patients as well as their family. Next slide, please. And I'd be remiss to not discuss other COVID stressors we've seen for nurses. Basically, there's a large sense of a lack of appreciation in general, especially in 2021. One nurse described how when she was after her shift in early 2020, this is the pots and pans being banged together for nurses on the streets of New York. Well, healthcare staff, I should say, not nurses. That she was pumping gas and a stranger offered to pay for her gas, taking her for her work. And now she's more at the point where she feels basically that she doesn't want anyone to even know that she's a healthcare provider in the hospital setting because of changes in the perception of what nurses do here and change the perception of COVID-19 and feelings of just kind of, I think, being overwhelmed and being done with it. But again, patients and family and the lack of appreciation, even beyond just the workplace violence, but just a lack of appreciation for what nurses offer and what they do. Many have noted a lack of appreciation by hospital administration that the staff go unrecognized for their work, as well as a sense of there's a disparity between the administration who might be working from home and that they are not as aware of what the staff go through each day on the units because they're working from home to avoid increased for infection prevention reasons, to avoid having increased people in the facility. The work is harder. Our patients have been sicker, partly due to delayed care, but also due to patients sick with COVID-19, and certainly less support from other parts of the hospital. Part of that's due to staffing. Part of it was due to pandemic-related restrictions. So we had, for a while, dietary couldn't bring trays in, so the nurses had to bring trays in. We had other staff who wouldn't go into COVID positive patient rooms for one reason or another to decrease risk, perhaps. But all of that meant the nurses had to go into the rooms more to do phlebotomy, to, as I said, deliver trays, to take more phone calls. And then certainly a level of fear about being in the environment and getting sick and bringing that home. And some of the moral injury that nurses had. So I call this like the macro injury of caring when the care is futile. So the number of patients who would be on ventilators much longer than expected because the ventilator was prolonging life that was ineffective was a problem, as well as some more micro moral injuries. Charge nurses that had to be in charge of who received a respirator or not early on in the pandemic when we had significant supply chain issues and some of the moral injury around managing that for their peers. Next slide, please. And I wanted to just paint a picture too of jail and COVID times. I know I just have a minute or two here. So next slide, please. In the jail, as you can imagine, and as we all heard in the news, the risk for COVID was very great, especially early on in the pandemic. There were very large outbreaks in the jail setting. The risk for violent outbreaks increased also in this time, just as similar to how it has been in the community. But part of that's related to some of the irritability of inmates. So inmates no longer had access to some of the resources they may have. So they would have less time out of the cell. They might have to be in the cell for 23 hours of the day and only have an hour out or less, able to get phone calls. And so the level of irritability amongst the inmates has increased, and then the clashes both with the healthcare staff as well as the deputy staff in the jail. And there's been greatly increased workloads, specifically related to the amount of COVID testing that has to be done in the facility to try to decrease the risk for outbreaks within the facility. And so the participants on COVID testing are, every time something is done for a detainee, it has to be done both by the healthcare provider and by the deputy, essentially. And so when there's increased healthcare tasks, there's also increased deputy time. And essentially, no one has downtime as the workloads increase to try to contain COVID within the jail. Staffing shortages and mandated overtime, probably not too dissimilar to what we've seen in healthcare as we've had staffing shortages. And unfortunately, some of these increased demands have led to conflict between healthcare staff and the deputies as their priorities kind of clash. Both need to get the work done that they are required to get done, but it just unfortunately runs into the time of each other. So, and that adds to a workplace that is quite a bit less satisfactory for both. So thank you, and that is the end of mine.
Thank you, Dr. Gramling. I really appreciate your insights and perspectives, both from the hospital setting, but also from the jail setting, and just, the impact, especially on workload, and then also the reality of the issue of violence and the increase in violence that we've seen on healthcare workers. I really appreciate that. And now I'd like to turn to our next presenter, Dr. Myra West. Myra. Myra, I can't hear you. We need to get better broadband to Marshfield, I guess.
Isn't that true?
There you go. All right.
Can you now? Okay. I am very sorry about that. I had that all set up and tested earlier, so not really sure what happened, but good afternoon, and thank you for the introduction, Dr. Bender. I am going to share my screen. As we get there, that threw me off, as you might imagine. So let me just pull that up very quickly. And we will begin. So thank you so much for having me at the symposium today. I really appreciate being here. Can you see my slides okay? Great. Oh, wonderful. Excuse me. So I am from Marshfield Clinic Health System, and I am a clinical psychologist who specializes in severe stress and trauma reactions. And I have been with Marshfield Clinic for about 5 years, and just last year moved into a new position that I'm very excited about. You can see this is our main campus of the Marshfield Clinic. We have over 60 clinical locations in 40 different communities throughout Wisconsin. And I won't go into all of the specifics there, but giving you a sense of our setup and what our structure is like throughout Wisconsin. So we are central, north, and northwest, and I have a west region as well. We recently just moved into the upper peninsula of Michigan also. So I'm sharing with you here some workplace violence statistics that we have specifically from our organization, and this is system-wide. So we have approximately 14,000 employees throughout the system. And so from 2021, these are some of the numbers that we experienced with workplace violence incidents. So 42% manager and security were contacted and responded. Law enforcement, 28% of the incidents, they were contacted and asked to respond. Physical incidents were about 38%, where verbal throughout the system was 70%. And I know Dr. Gramling shared some national statistics, so I just thought I'd skip right through those things. So why do workers feel uncomfortable providing reports and making reports? And there are several different reasons for that. We are trying to improve throughout the system. And you all might be familiar with new Joint Commission standards for having sort of amped up workplace violence programs and responses. So we will go into a little more depth in that shortly. Last year, we began talking. So I had been full-time patient care, but when there were critical events that occurred throughout our system, HR began to reach out to me. And so we were able to provide a response and support those employees who either were directly involved or witnessed it, or some sort of involvement, even responding to it. So a proposal was made to develop a program that is strictly supporting our workforce members and supporting them related to severe stress, trauma, reactions, potentially traumatic events, either at work or in their personal lives. So individual sessions are held with the employees, but we also do group or team meetings depending on what the needs are. Our team responds to difficult codes, difficult patients, critical events, as I said, workplace violence, and also really welcoming discussion of personal difficulties. And we all know we try to leave our personal stuff outside the door. And the past few years, the amount of stress that has been on healthcare providers, we know sometimes that can be a struggle, not to mention with all of the stressors going on at work. So we're providing these supports in efforts to also retain the incredible workforce that we have. We know there are staffing shortages nationally, so we're really trying to identify ways that we can support our workforce and keep them there. As you know, in rural areas, it can be really tough to get some of our positions filled. So other parts of this program include rounding, and was primarily focused on the higher stress areas in the hospitals, but then branching out and also opening up requests that we can respond to any area if there is a need. I was a one-man show for a little more than 12 months. So we were trying to pilot this and keep it on the DL a bit just as we were branching it out. We've had quite a bit of success, and I've met with over 300 employees, which may not sound like a lot through 14,000 members of our workforce, but those are individual meetings that I've had and not counting the team responses or departmental responses. In addition to that, you can see that I would go to the units and just sit for a few hours and let everyone on the unit know where I was. And if anyone wanted to stop by, they could. We're also working on implementing a trauma-informed care organizational model. And part of the rationale for this is essentially providing opportunities for more in-depth conversation and cultural shifts. So coming from the trauma field, I definitely appreciate trauma-informed care models. My proposal to our organization was that if we're taking care of our employees will take care of our patients. And if we can improve our environment, which of course was exacerbated by COVID-19, then that will ultimately positively impact our patients, their families, and our community. So again, focusing on, with a little bit of a twist towards trauma-informed care, but really focusing on the workforce and applying some of these practices to them, given the amount of their severe stress over the past few years. And we hear a lot about difficulties since COVID. From my perspective, a lot of these struggles were there. These are stressful jobs that our workforces are engaged in. And so I view COVID as exacerbating what was occurring already. Obviously, it definitely intensified, but this was a significant shift in really acknowledging that our entire workforce has suffered as they dealt with all of the changes COVID has brought. We also have developed a workplace violence response where now when individuals file a report of unprofessional behavior or any type of violence, threat, intimidation, there's a team of us that sees these reports, and they do not go directly to the manager. These reports are restricted to our team, the Human Resources Department, security, and a few other individuals so that we can then respond. Our team is not at all involved in the investigation or gathering of information. We reach out to each individual and offer support to them following the event. And we include a description of the program as we are very new. So again, I've already mentioned the benefits that these implemented interventions will have on our entire health system, patients, and communities. So some of the things that our team has also done is really coordinated with other departments throughout the system to develop, enhance, and support programs that were already there. We're trying to weave in some of the trauma-informed care practices for our workforce into already established programs. When COVID hit, multiple departments pulled together, and at the time I was in our behavioral health department, and we created a social emotional support line, initially just for our workforce. We then opened it up to community members as well. Heroes Health was a study through UNC North Carolina, and it is an app that is strictly for healthcare professionals, anyone in the healthcare industry, where individuals could complete a survey each week. And it's a brief survey, couple of questions on sleep, irritability, any type of potentially traumatic exposures, and any suicidal thoughts or behaviors. A team of us within the system, and again, this is a multidisciplinary team, would get those responses. And if someone was identified as a low, medium, or of course, high risk, they received contact from one of the members of the Heroes Health Response team to check in with them. Our team offered supports to those individuals, which a lot of them took us up on. And after a couple of wellness meetings, as we refer to them, they felt, well, they reported feeling better. And so we have significant gaps in time where we may touch base with an employee. They are not our patients. No documentation goes into any medical records, employment records. We have an external HIPAA compliant software that we utilize to keep track of who has come in and what resources we've provided and what supports. We are not doing psychotherapy. This is attempting to connect and develop relationships with our entire workforce as colleagues and coworkers, but also trying to provide supports for the workforce. We have collaborated with some of our faith leaders here at our main Marshfield location. Some of our faith leaders reached out to us and asked if they could come and round on some of our units to provide supports, again, for those that were in the COVID units or ICUs and some of those high stress areas. So this has started approximately in the last 8 months, and we are now signing up additional faith leaders to come in, and they are assigned to a specific unit so that they can develop connections and relationships with those individuals. And then, they come on the unit and people are just, oh, hey, there's John, or I know their names, but just not throwing them out there for now. In addition, we set up 2 different types of programs. Care for Our Caregivers, which is obviously listed there, is a program where we accepted donations of any kind. They could be monetary, they could also be items that would support wellness and trying to care for our workers. So with those donations, we were able to, if an individual was struggling during that initial period when we had some of our outpatient staff furloughed for the first few weeks, we were able to utilize funds from that program to help our employees while they were not able to work. Many of us kept working, right? If they're working in a hospital, they're continuing to work. We saw increased symptom severity in the behavioral health department, and we were able to move to telehealth appointments in 4 days in our department, with having the majority of us not participating in telehealth prior to that. Helping Hands is another one of the programs that really originated out of COVID. And what that is anyone throughout our health system could volunteer to go into the hospital and perform any duties they could to take that off of the medical staff. So answering the phones, cleaning out garbage and changing bedding, sanitizing rooms once a patient was discharged, and also patient sitters. So this was something that I've spoken to so many people who volunteered that were in administration and really had never experienced the hospital environment, and talking about how beneficial it was for them to support their colleagues. A few other proposed programs that we have right now are, you can see them all here. And so the Organizational Trauma and Resilience team is trying to find an acronym that isn't so long. And so what we're throwing around these days is HEARTS, and healing employees while acknowledging reactions to trauma and stress. So that is what our hearts room is there. And gratitude carts, we sort of got this idea from Froedtert Hospital down in Milwaukee. They utilize gratitude carts for their workforce, where they put a variety of different kind of items on there. At Froedtert, chapstick is their most popular item, specifically EOS chapstick. But just pushing it around, chatting, leaders can take the carts and push them around and provide our workforce with anything they would like to take off of the cart. And we also plan, once we implement it, to have cards on the cart so that they can also request specific items that they'd like to see. We're in the process also of developing recharge rooms so that on units, employees will have access to a dimly lit room. We are hoping some massage chairs that we see in the mall, sometimes if malls still exist, which they do in Minneapolis, and even a water fountain, soothing music, and aromatherapy items, so that in the event that someone needs a break, whether it's 5 minutes, 10 minutes, to be able to verbalize, I have to step away for a minute. We know there's a lot of our workforce that don't step away for lunch, or they're picking at it throughout an extended period of time, or even trying to get out to the restroom. So really trying to find ways that can draw them in. And, anyone in healthcare, they care about people and they want to take care of them, as we know. So really trying to think about ways we can care for them. And I will throw out one more note about the act that was recently passed for healthcare professionals. And I won't go too much into detail just because of time constraints, but I'd encourage you to look that up, because there are now, it's a variety of misdemeanor up to felony charges for threats, intimidation, physical assaults, obviously, but this is why we're also developing tools to promote keeping our workforce safe as well as our patients. And we want to make our patients aware of the need to keep all of our staff safe. So I will stop for now and hope I didn't go over too long.
Thanks, Dr. Ross. I really appreciate you sharing your work, especially, at Marshfield, and some of the interventions that you've done. I just want to remind folks to, if you have questions, please put those in question and answer chat box. And I'll move on to our next presenter, our Dr. Casey Clements at Mayo Clinic. So, Dr. Clements, I'll turn it over to you.
Thanks very much. And I'm not going to speak to slides. And I appreciate everyone's attention. 2 hours and 40 minutes has been is a long roll for everybody, but we'll try to at least make this interesting. After listening to Dr. Derby's talk, I felt very seen. So I was invited here partly because I'm the clinical practice chair of emergency medicine here at Mayo in Rochester. And so I help lead our practice here at Mayo, and I spend half my time seeing patients and half my time within leadership. The other administrative role that I fill is I am the staff safety officer. So I lead our occupational safety team for Mayo Clinic here in Rochester, as well as at the enterprise. And my full disclosure, my own personal research and scientific as well as quality pursuits center around three things, which I never thought would relate to one another in real life practice. It is emergency infection, chemical use disorder, and specifically around opioids. And really, most of my efforts are around workplace violence, both measurement, mitigation, and response. And if you would have asked me in 2019, I used to joke about having multiple personality disorder when it related to my academic endeavors. And now, unfortunately, they all relate to one another. And so I'm going to cover a couple of topics really that go into two broad categories over the course of there's only about 5 minutes left, unfortunately, until we're going to do some questions and answers. So I'll move quickly. But we essentially two broad categories. One is, what are we doing to protect our workforce, and how has that changed within the COVID pandemic? What have we learned? I think that will relate directly to a lot of where the students are learning, as well as many of the attendees. And number two, what are the changes inherent to patient care that really change our paradigm for sustainability and safety of a workforce? And within those two categories, one is, I think we should go back in time. So first of all, we crossed the threshold of 1 million deaths yesterday in the United States. This is an almost unfathomable number. But if you go back to the beginning of the pandemic, it's very easy to forget now, as we continue to deal with this for over 2 years, what it was like at that time. And it was extremely scary and anxiety producing. And I remember talking to our psychiatry colleagues, very much like Dr. West's role, and saying, what can you do for our emergency providers related to anxiety? Because this is scary. And they said, well, we have to be very leery about about confidentiality of staff, because there are people that might not want to say that they're anxious. And I laughed right out loud. And I said, I don't think you understand. All of us are anxious. We know that. But what we need to know what to do with that, if that makes sense. Well, COVID has really turned into a watershed moment for worker safety. Within occupational safety, a lot of the thoughts of what we did were regulatory, or sometimes not really an afterthought, but they might be further down a checklist of things that we wanted to make sure that we were accomplishing as we were moving forward with our patient care goals, our research goals, and our educational goals. That's not the case anymore. We've learned through COVID that workers really have to feel safe in order to be able to continue to work. There is a not insignificant number of people that have decided that they don't want to do healthcare anymore. We've seen that in massive changes within the nursing force. We've also seen that within a lot of data that's coming out now within the physician healthcare force, where 1 in 5 physicians want to leave the practice of medicine within 5 years, and 1 in 3 want to decrease their clinical time. That is very much an effect of the pandemic. Yes, there were pre-existing traumas. Yes, there was pre-existing depression and burnout, but it is on an entirely different scale at this point. The things that scare us and the things that upset us are not necessarily what you might think about. Very few healthcare workers are actually worried about getting COVID themselves as much as they're worried about the effect that it may have on their family or their loved ones, particularly those who are medically vulnerable, and being able to deal with that. How we actually interacted with safety measures was drastically affected by media in a way that it wouldn't have been before. Who would have ever thought? I mean, a lot of the students on this webinar and a lot of the professionals work within the safety field. Who would have ever thought the amount of discussion that we're going to have around personal protective equipment within the media and within our public discourse pre-pandemic? It was always something that was oftentimes an afterthought. And people have preconceived notions that they still don't necessarily always understand. But what we saw on the TV mattered, right? So when we're trying to orient our workforce towards best practices and safety, what they saw on TV was people wrapped up in spacesuits a lot of the time, taking care of these patients early in the pandemic. And then we're telling them they can go take care of patients without that same look to it, or without that same feel, because of emerging evidence. And that leads to some distrust in our systems. And I think that there's a lot of learning points to be had there related to that. And along with that, I think one of the things that both the American public as well as healthcare workers in general have learned around workplace safety and infection prevention is that we're not comfortable with dealing with the unknown. We want things to fit into a narrative. And I've known this for a long time, because when you diagnose someone with something bad, their immediate first question is, why did this happen, or what could I have done to prevent it? And the answer to that is almost always, this was bad luck and we don't know. Well, that we don't know answer has been a lot of COVID, right? And particularly early in the pandemic, we didn't know how this spread. We didn't know what we had to do to protect ourselves. And that march towards understanding what to do and how this works is very uncomfortable. And it didn't always fit people's narratives with what they expected or what they thought would happen. And so that's really been a challenge. The other part of workplace safety that I wanted to point out was the importance of pet projects or other agency and control within a crisis situation. So as we look at the things that excite us within, for example, academic medicine, it's teaching, it's research, it's looking at, novel and interesting projects. All of those were taken away. And within the general practice of medicine, elsewhere, the things that reinvigorated people even outside of work, such as travel or other commiseration with their family and friends, wasn't available. And that lack of support has continued to be a problem as we still deal with that idea of social isolation. Moving along to the bigger category of sort of how has patient care changed and how that may affect workplace safety as well as sustainability, I think that there's a couple of things that I'd like you all to be aware of that you may not be privy to. In general, healthcare is an extremely rigid system of patient care delivery. And we know that, for example, even when there's new evidence published about how to change a best practice in medicine, it takes 17 years on average for that evidence to translate into practice change. Now, when we came to COVID, we started at 0 and had to move to 100 within a couple of days. And I can tell you, in our practice of emergency medicine here in Rochester at Mayo, we made 469 individual practice changes between the dates of March 11th and December 15th of 2020. Every single day, we were changing sometimes upwards of 10, 15, or 20 things at a time for what they did today versus what they have to do tomorrow. That breeds a level of flexibility, which has been unprecedented. And I'm extremely proud of our team for being able to do that. But it's also not anything that someone here had signed up for. That's not how we generally had done things in the past. It was just required. And the trauma that Dr. West had talked about, and some of that part of this is because we have whiplash for how things have changed over the course of the pandemic and continue to do so. Can anybody name which monoclonal antibody works for the BA2 variant? It's different than it did for the Omicron variant. It's different than it was before that. And trying to keep up with that stuff as we care for other patients is a unrelenting challenge. Secondly, I think that we need to acknowledge the cost of patients choosing not to seek care for what they would have otherwise sought care for before. In April of 2020 in Minnesota, our volumes within emergency departments and hospitals were extremely low because we were hearing about overcrowded hospitals in New York City, and people were thinking, A, they didn't want to catch COVID by coming into a healthcare setting, or B, they didn't want to be in the way because there was going to be COVID patients who would need it. And we ended up seeing, illnesses that generally wouldn't have progressed to the level that they did by the time we saw them. And that burden of illness and complexity actually was much higher than expected. Josh kind of said, the patients are sicker. I think that was a quick sentence, but it means a lot actually, because right now the patients that we're dealing with in healthcare settings are generally much sicker than we were dealing with before, partly because of delays in care, both in and out of hospitals. And lastly, I will just also highlight the point of violence. I know that my co-presenters pointed this out as well. All of the data that we have, including the most recent labor and statistics, was from 2018, would say the healthcare industry is 5 times more likely to suffer violence than any other sector of the economy, That was pre-pandemic, and we've heard sort of on popular press and news agencies about the feeling that that violence had increased with COVID. We were actually the first to be able to measure this here, and we're right in line with my colleagues at Marshfield and at Hennepin. We're in the Rochester Hospital alone, we're at about 500 violent events a year, and that's specifically physical violence. We also know that in healthcare, only 19% of violent events are ever reported. So you can generally take these numbers and multiply them by a factor of 4 or 5 as a reliable increase. When we did measure this, we actually can directly relate violence in healthcare to the hospital referral region rate of COVID. We published this in the American Journal of Emergency Medicine, and you can see that as COVID started within our region, the violence rate in healthcare doubled right away, and it stayed at a doubled rate until approximately October of 2020, which is when we started to have the Delta wave. or at least the big first wave, I'm sorry, in the fall of 2020. And then our violence rate tripled, and it only returned to a baseline after that rate had sort of decreased again. So this is actually a scientifically measurable phenomenon for those who would like to say, well, this isn't necessarily pandemic related. The pandemic has made it worse. And it continues to be one, I think, of the biggest threats to staffing in healthcare. So there you go. I was asked to stop by 2:50, and I will stop, and I would love to take any questions or talk about this. I think that this has been a great webinar this afternoon. I'm very impressed with all the safety professionals that you all are training, and looking forward to working with them as we work regionally.
Well, thank you, Dr. Clements. I greatly appreciate your perspective. You really bring up some really interesting, concepts, some of which I really hadn't thought about. I mean, just the fact that our daily work patterns have changed, and basically the continuity that our workers would expect on a given day changes from week to week, and just the stress of having to deal with that, and then basically re-emphasizing our violence issues that we've got, and then basically our patients, our change in our patients, and what does that mean? So really appreciate that. So at this point, if we could bring back all the panelists, and I know we've got a series of questions for folks, and I look forward to this ongoing discussion. Andy, if I could put the pressure on you, can you get us all on the same screen? Great. All right. Well, again, thanks to all of you. Let me just check my Q&A areas here to see what I've got, and I will start asking some questions. You should be able to feel free and have the panelist prerogative to ask each other questions too. So let me go ahead and start. Josh, can you comment on the level of staffing change due to violence? Are you short-staffed because of basically violence in the workplace? Or is this more related to burnout from the pandemic or long hours? Can you comment on that?
Sure. Thanks for the question. Yeah, the short staffing that I've discussed is much more related to what was mentioned earlier about the kind of great resignation that we're seeing, the difficulty organizations around the country are having with recruiting and hiring. Part of that is especially in the jail, especially the difficulties with recruiting deputies to work in the jail is very difficult right now. Part of that is, I think, a general lack of interest in being part of law enforcement right now, and that's a whole nother subject too. But they've had difficulty recruiting, which leads to difficulty providing healthcare to patients because we can't actually get access to patients without deputies. And then which leads to more irritability for patients and burnout for the nursing staff and medical staff there too. So it's a tough thing, but in general, the staffing issues we see are not directly correlated with workplace violence necessarily, although we do see people leaving the profession because of workplace violence.
I will actually point to some information that we're publishing. It's under review right now, essentially where we've asked workers across emergency departments throughout our Midwest practice of what the effect of violence has been. 20% of them have said that they have considered leaving their position because of violence. And I would just highlight one of the things that Dr. West said that I think everybody needs to hear, which is it is not anyone's job to be assaulted in the workplace. The other thing that I want to be very clear about, and I would be interested in my co-panelists' views, is that we need to also be very clear that this is not a problem of primary mental illness. With the emergency nursing literature that has been published, less than 5% of healthcare-based violence is related to mental illness. The vast majority is related to chemical health, as well as other behavioral issues such as personality traits or personality disorders. Those are not the same things as what people tend to think of mental illness. And I want that to be clear that this is not folks that don't necessarily know what they're doing. Over 70% of healthcare-based assaults are committed by lucid individuals.
Yeah, I appreciate that. Maybe, Myra, next question for you. And actually, I'm going to take a little bit of a prerogative myself. One, because when I think of Marshfield, I think they really do serve a broad rural area. And I know you focused a little bit on the central, you being able to walk, the hospital hallways. But what about the satellite clinics, the clinics out, how do you provide support for our rural clinics?
Great question, and thank you for asking, Dr. Bender. I have had focused on all of the hospitals throughout our system, but now that our team is growing, I am going to the clinics as well. And that has always been part of the plan, is that by the end of this year, that I am at every location that we have. And just yesterday, I spent some time in one of our clinic locations in Merrill, Wisconsin. So a little north of Wausau, but south of Minocqua. So we intend to do the same thing, and having those connections and meeting everyone there so that they're starting to feel more comfortable opening up to us. That is essential to me, and we are and have been entire workforce health system focused.
Sounds great. Good. Dr. Clement, bear with me as I read this question here. Working in the ER has always held an element of additional risk for healthcare workers as compared to other settings. Has the additional stress of COVID-19 pandemic combined with the risk intrinsic to the ER setting contributed to burnout in healthcare workers? So that's first part of the question. The second part of the question is, are you seeing a problem of healthcare worker shortages rebound or improve at all in the last 6 months?
It's a really good question. And I think one of the issues is what burns us out, right? It's not necessarily busy shifts, and it's not necessarily sick people. The things that burn us out are oftentimes working in a system where we feel either alone and unsupported, or we feel like we're not able to help the patients in the way that we can, or we feel that we're, unduly affected, right? I think those are a lot of the things that I would view as affecting burnout in an emergency department setting. In general, I have felt less burned out while working on shift, except around the decisions of what we do with specific patients where we don't feel like somebody's able to get the help that we would want them to do. And a lot of the rest of that burnout is around this sort of administration of medicine and the administration of how we arrange our lives. And so I don't know that why this is more specific to the ER, except for the fact that we're the one place in healthcare that doesn't cap. Like, if you fill a unit with hospital patients, you can't add more patients at some point, right? If you fill an operating room with operative patients, you can't add more. If you fill all of a clinic slots, you can't add more. But in the emergency department, people can keep coming in. And so if you have operational challenges within a system, those things are compounded and there's no pop-off valve necessarily. So I think that's why the ED is a little bit worse off than some other things. And then the second part of the question about have we seen healthcare shortages rebound in the last 6 months? My answer to that has to be no right now. I'd be interested in what other people have to say about their organizations or their situation. But I'm continuing to see somewhat of an exodus from healthcare. And yes, the Great Resignation has affected all sectors of the economy. I think healthcare is worse.
Yeah, and also one of the things that struck me that you mentioned as well is the pet projects, the loss of the pet projects, and the diversion that the pet projects actually, this is something I enjoy. You just took this away from me, and so this is something that Dr. Derby said is that, well, what keeps people, from not burning out? And part of that is the things that keep you excited about your job and that type of thing. So I thought that was an interesting corollary that you brought up as well. Josh, I think, let me bear with me here. How do you encourage more students? So this actually relates to a workforce question. More students to sign up for nursing degrees and thus release the strain of our existing workforce. So here's your motivational speech to attract more folks to nursing, please.
So I guess I can just be personal. and I certainly, when I was in nursing school, had no idea what nurses did to some degree and what they were faced with. And that being said, I never would have chosen a different profession. So mine could just be a personal experience discussion and point of just saying, as difficult as the work is, it is still supremely rewarding for most folks I know, although certainly burnout can be a very significant factor. And with nursing, there's always so many things you can do. So if you don't like that spot, there's other ways to change and move into different areas in nursing and give different people an opportunity. But it gives you an opportunity to be close to people in ways that most professions don't give you that opportunity.
Appreciate that. Myra, I got a couple questions for you, but I'm gonna take my prerogative again. One of the questions deals with lasting psychological consequences of COVID-19. Can you comment on that and what you anticipate that and how you're trying to address that?
Yes, definitely. I feel that this is present now. I don't have statistics or research on this yet, but from my experience, I've been seeing people who they don't want to come back out and be social. And so we're seeing more withdrawal and isolation. And if we put this in the context of a stress or trauma response, these are actual reactions to having severe stress responses, and how the physiology of our bodies are impacted, as well as our thoughts, emotions, behaviors, and relationships. So I believe we're seeing increased depression, anxiety, and I would argue trauma reactions as well. And from my perspective, it's irrelevant if someone meets criteria for a post-traumatic stress disorder diagnosis, because the way I was trained and how I focus is what are the reactions and what's the severity? And we focus on reducing the severity. And a lot of our workforce has expressed, I feel like I'm traumatized, as you've all noted as well.
Yeah, I'm looking at my clock here. I have two questions left. One question that just came through that I will open up to the whole group here is that there's a growing aversion to using the term burnout and a preference towards moral distress or compassionate fatigue. Operationally, does this reframing matter in your opinion? If so, how? Anybody want to tackle that one?
Well, I can jump in and I'll try to be brief. I know I'm wordy. So there are even slight differences between burnout, compassion, fatigue. We also have a term, vicarious trauma. So there are several different terms, and I try to avoid the it terms, and I don't know, maybe that's just my rebellious side in me, but I think that moral distress is speaking to a larger perspective of there are reactions to that individual as well, and how they are feeling they've been impacted by organizational guidelines and practices, which is not a negative statement. It's a product of how things need to function in business while we're also trying to take care of our workers.
I don't like the term burnout, to be perfectly honest. It implies permanency. You can't unlight a fire. If you have something that has burned up, it is now gone. It is destroyed. And that's not generally what we're talking about. I do prefer other terminology such as emotional exhaustion. I think that implies, oh, you need to do something to make yourself better. And that's what we see, right? When we measure burnout rates, those are at a given time. But Dr. Derby's and other researchers' work have shown that burnout, everybody has burnout sometimes. And so it's the trick is to minimize it and reduce it. And so I really appreciate the question. I really don't like the term burnout.
Great, I appreciate that. I'm looking at my clock and knowing that my minders are whispering in my ear. I have one last question, one because I want to end on a positive or a more hopeful note, because this is a hard topic. And so the question that I'd like to pose to the panel is, what is an example of something that has taken place in the last year that is a true success or inspiration that gives you hope? So, Dr. Clements, I'll put you on the spot first, and then I'll go around the virtual room here.
Yeah, I made an allusion to sort of monoclonal antibodies or whatever, and we made the decision we wouldn't be able to give those in the emergency department because of operational challenges. And our people within our hospital stepped up and said, we'll find a room, we'll staff it, we'll be able to give these to people. Why don't we work out a way to do it together, because they're probably the right thing to do for the patients. And I told you the things that burn us out are operating oftentimes in isolation. That collaboration to do something innovative, even though it was directly related to COVID and it was still related to the problem, it really was uplifting, and it's something that I can point to and say, look, we did a cool thing. And it gives me hope that we can get to that collaborative environment.
Sounds good. Dr. West, I'll put you on, and then Dr. Gramling, I'll give you the last word. So, Dr. West.
I would honestly say the support from the organization to develop, implement, and grow this program, and ongoing, based on the response that we had gotten just in the first several months. So their investment in other ways as well in supporting the workforce has me very encouraged and wanting to hear from those on the front lines. What else can we do? How can we help? So I'm really excited about the process.
Sounds good. Dr. Gramling.
Thanks. I think my answer might seem a little obscure, but one of the things that our organization is undertaking, and I think this is true of many organizations around the country, is an increased focus on equity and inclusion, and increased understanding of the importance of trauma-informed care in like all aspects of what we do. And the more staff can kind of understand and encompass these aspects of relational activity to each other and to our patients, the less risk there is for patients to escalate in the first place. I can give the backstory to that marker that I showed in the picture. When I heard this story, my first thought was, well, what happened in the first place? Because I heard the story and thought other actions could have been taken and things could have been de-escalated earlier. Perhaps I wasn't there, but in my thinking, there could be questions that could have been asked that may have helped create a bond rather than reaffirmed a difference.
Well, thank you, Josh, Myra, Casey. I really appreciate your inputs, especially with this topic. I think it's very timely, very important. And I think we need to dedicate some energy to this. So again, I want to thank you. I also want to thank the audience. 3 hours is a long time for joining us today. And a recording of today's event will be available on our website. So please feel free to refer your colleagues who might be interested in the topic, or others who are interested in this topic. Please remember to complete the evaluation, as your feedback is incredibly important to us as we plan for future events. Once you leave the online event, the link for the evaluation will pop up, and so then you can answer that. If you're interested in free continuing education credits, you will receive a link to get your CE certificate, and that will occur following your completion of your evaluation. CE credit will also be available for those who register to view the recording as well of this event on our website, and should be available for viewing in early June. On behalf of the Midwest Center for Occupational Health and Safety and the Upper Midwest Agricultural Safety and Health Center, I want to thank you for attending our annual NORA Symposium. And with that, I hope you enjoy the rest of your afternoon. Take care.